Hello, everyone, and welcome to the Natus Neurotraining Academy webinar presentation. I'm Dr. George Grodziak, Senior Global Medical Education Manager for Brain and Neural Pathways, and it's a pleasure having you join us. Our webinar is entitled Excellence on Demand, Transforming Education to Overcome Healthcare Challenges, featuring Julie Pagel. Julie Pagel is a neurocritical care nurse specialist at Natus. She has clinical practice experience in both medical and neurosurgical intensive care settings, totaling over 12 years, along with serving as a neuroscience divisional educator at a Level 1 Trauma Comprehensive Stroke Hospital in Charlotte, North Carolina. She also served as an adjunct faculty at the University of North Carolina at Charlotte for 8 years. Julie is currently responsible for the education of clinicians, including curriculum and competency development, instructional design, and multimodality delivery. Her master's degree specializes in nursing education, and her doctoral work investigated the effect of early mobility on functional ability of stroke patients post-TPA. She has presented her work nationally on topics ranging from adult and pediatric stroke, creation of a neurointermediate unit, interprofessional education, innovating teaching strategies, simulation, and cultivating clinical reasoning. She has published on nurse preceptors and new graduate nurses' transition into practice, along with the impact of COVID-19 on new graduate nurses' success. She is passionate about the promotion of neuroscience nursing through her involvement with the American Association of Neuroscience Nurses, including serving on the board of directors. So with that, it's my pleasure to turn the presentation over to Julie Pagel.
Thank you, George. Appreciate it. Hi, everyone. Thank you for joining. I'm excited that today we will be talking about excellence on demand, transforming education to overcome healthcare challenges. George already mentioned these, but here are my disclosures. I currently work for Natus as a neurocritical care nurse specialist. I also serve on the board of directors for the American Association of Neuroscience Nurses. And if we have any neuro nurses attending and you aren't familiar with AANN, please reach out. I'll be happy to share all the resources that you have available to you for free.
Hey, Julie, excuse me, do you want to, is your webcam working or is it turned off?
Yes.
There he goes.
Thanks.
Thank you for that.
Yep. Okay, so here's what I hope to accomplish today. First, we will discuss the current challenges in healthcare that we have and still are experiencing that have impacted education and our clinical practice. Second, we will compare educational modalities and their use in healthcare. Third, we will, I'll describe just-in-time training. What is it? What can it be? And lastly, I will show you examples of just-in-time training used in healthcare as a solution. We're going to start by taking a trip down memory lane. Inevitably, we all know the pandemic has impacted education in our current healthcare state. It caused major changes in education, starting with a shift to remote learning and a significant reduction in clinical experiences. The ongoing nature of the pandemic disrupted healthcare education for extended periods of time, requiring programs to quickly pivot. So some of the things include early on colleges restricting occupancy for classroom, which required online class delivery. Students who had to quarantine often missed learning experiences. At the same time, clinical sites were experiencing heightened patient acuity and volume. Units were flipping to hot COVID units, and there was a drastic increase in staff stress. All these things impacted clinical learning. In turn, this reduced exposure for students and decreased their clinical time. Similarly, among residents, there was a negative impact regarding technical skill development with lower operative case volumes and an overall lower utilization of skills. In 2021, we saw the first cohorts of pandemic students graduating. Research indicates that faculty perceive pandemic graduates as being less prepared for professional practice, and this can create patient safety and workforce concerns. Meanwhile, another study found new nurses who entered the workforce in July 2020, so July 2020, less than one semester of disrupted clinicals, reported feeling more anxious and less competent. The limited research indicates that there also may be a reduced level of practice readiness. I was part of a study team that worked to quantitatively describe and compare nurse faculty perceptions of readiness for practice among nursing students. So those who graduated pre-pandemic and those who graduated or were graduating during the pandemic. We surveyed a sample of faculty who taught in pre-licensure nursing programs across the state of North Carolina. Our sample size was 116. We captured we captured many things, but two things that I want to share. The first is changes that occurred due to the pandemic in the students' didactic, lab, simulation, and clinical courses. You can see that displayed here, highlighted. The one I want to point out is the changes in the clinical teaching section. The highlighted box shows clinical rotations were canceled, changed to simulation, changed to case study completion, and clinical time being decreased. The second thing we captured was nurse faculty perceptions of readiness for practice among new graduate nurses using the NPRT. It's the Nursing Practice Readiness Tool. It's a 36-item tool. This assessed graduating students' proficiency level for entry-level nursing competencies on 6 subscales. And you can see those listed on the bottom of the slide. They were clinical knowledge, technical skills, critical thinking, communication, professionalism, and management of responsibilities. The portion highlighted is technical skills. Our study showed that there was a statistically significant decrease in scores, with technical skills having the highest decrease in scores, along with critical thinking. Also from our study, faculty believe pandemic graduates have a steep learning curve. They shared how the upcoming graduates are feeling anxious and having self-doubts about their skills. Many are aware of their clinical weaknesses and recognize they are entering practice environments they are not prepared for. Several faculty stated there will be a disconnect without live clinical and relying on virtual platforms to try to induce critical thinking. Students will experience reality shock greater than we have seen in quite some time and will need ongoing real-time support. I want to stress that real-time support piece. We're going to be touching on this later. We all know that operative cases were also significantly reduced during the pandemic. I think this is a good graphic reflecting the severity, the magnitude of this issue. This is just one example from New York, highlighting the general surgery chief class in 2020, who graduated at the height of the pandemic. This was the first class not to meet all defined category minimums within the first 20-year history of the general surgery program. On top of the academic challenges we talked about, throughout the fall of 2021, travel nurse demand continued to rise as hospital census volume increased. So this is where we land. Our current challenges stem partly from post-pandemic changes, along with changes to the state of healthcare. First, we have new nurses entering the profession. In 2022, more than 150,000 new nurses entered the workforce. With current shortages, that number is expected to increase year after year. Younger nurses are making up an increasing proportion of the workforce across the country, elevating the number of inexperienced nurses in all settings. The 2022 National Workforce Survey revealed greater than a third of the nursing workforce has less than 10 years of experience. And like I mentioned previously, we have nurses who have graduated with missed learning experiences, decreased clinical time, and more virtual learning. Even pre-pandemic, the transition into practice period was problematic. So in the first 12 months of practice, new nurses, new residents often experience transition shock. They are adjusting to their new environment and they realize the many difference between being a student and a professional. As a student, you have fewer patients, less interaction with multiple teams potentially. Then you enter the workforce, you have sicker patients, a quicker pace, more collaboration, more communication across multiple disciplines, and you're experiencing firsthand how staff turnover feels. Further magnifying this stress, I guess you could call it, you are quickly required to acclimate to your professional role, including keeping up with your certification or your licensure status. We also continue to experience staffing shortages, which are mainly due to an aging workforce. Many nurses are retiring. I believe the statistic is greater than, like more than a quarter of current nurses intend to retire or leave. There's the growth of contract nursing, which allows for higher pay, and heightened rates of attrition due to stress and burnout. This one makes my stomach turn, but approximately 200,000 nurses, experienced nurses, left the workforce because of the pandemic. The importance of all this extends post-pandemic to today. There are continued disruptions, continued changes, and ongoing pandemic-related educational changes are still present. For example, let's talk about the bullet virtual learning. It has its benefits, and some students, when surveyed, want aspects of their learning to remain virtual. They say they appreciate the flexibility, they like the convenience of virtual learning. But we as leaders, we as educators, we need to determine what is appropriate for virtual learning and what is not. And it used to feel, or it still does feel, like playing whack-a-mole. You fix staffing slightly, but now you have an influx of new residents, or you're consistently getting nursing students during clinicals on your units, but you have an increase in travel nursing and not enough people to orient them. This is not meant to be discouraging, but to identify where we are so we can adapt and change how we do things to meet the needs of the clinicians. There will always be some conflict or issue going on, so learning to enjoy our work while still pivoting and solving the issues. So the why, or where are we now so we know where we need to go? The current challenges we need to work to overcome are: one, less experience, both in the sense of a younger team and more contracted staff; decreased clinical time and exposure across all disciplines, which has led to a reduction in comfort and competence with technical skills. Students' loss of clinical learning during the pandemic, along with faculty perception of students being less prepared, are important considerations when developing and delivering education. In addition, there are broader organizational pressures, including changing priorities and limited resources, right? The cost of recurrent training, access to training, environmental issues or constraints. These are just some of the pressures. Now, what are some strategies that healthcare facilities can proactively use to bridge the gap and to support new clinicians? We're going to look at some educational modalities and their use in healthcare. Hands-on learning, didactic and virtual opportunities, in-servicing, these are all great options for education. They all have advantages and disadvantages, and we're going to discuss good opportunities to use each and why. Healthcare education has historically been reliant on hands-on learning to develop knowledge and skills. This is non-negotiable. We must have these to learn and practice and implement new skills. Simulation is one very beneficial method, whether low fidelity or high fidelity. I could have a whole lecture on sim. I love sim. Throughout the literature, it speaks to simulation improving communication, problem solving, helping with clinical reasoning, and many other things. Earlier, I mentioned that during the pandemic, clinicals were switched to simulation. Often this was changed to vSim or virtual sim. As a clinical instructor, I used to lead vSim during the pandemic. While learner survey results may demonstrate high rates of satisfaction, there are challenges such as realism. A systematic review of 18 studies found that while virtual simulation may be a suitable alternative for, let's say, if you have to rapidly, get out information, or I don't know, giving them like theoretical knowledge, a knowledge base, it is a good option, but it may not be the best option for teaching clinical skills. Annual skill fairs are commonly offered to provide refresher education, and it's a great way for clinicians to get some hands-on rapid-fire education. However, clinicians frequently verbalize reviewing devices, reviewing interventions annually is not sufficient to maintain competence and their overall comfort. Literature shows skill fairs do not prevent safety fronts from occurring as well. Another common method is utilizing a super user approach. I think this is a great strategy to provide support during the implementation of a new product or a new process or workflow to cascade the information down. Some facilities report this system as flawed. Sometimes it's used to only train, a core group or team to care for specific patients or to perform a specific procedure. And opportunities to care for these patients or to do that procedure varies. What if the super user isn't available? Essentially, it cannot be the only modality for education. Embracing didactic and virtual opportunities are an option to ensure the continuous development of competencies. Didactic lectures and teacher-directed courses are still useful, they're still effective for both the immature learner and those that need a good knowledge base. However, these need to be gradually weaned off as 1, a learner's maturity increases, 2, experiential learning, practicing in real-time situations become more interesting, and 3, experiential learning triggers, it boosts internal motivation of the adult learner to learn. Both didactic and virtual opportunities, and potentially even hands-on, require a compromise between allocating clinician time to gain experience on the units and time off the unit to attend the education. This has a subsequent impact on costs associated with class time and staffing the units with additional staff. In-service training. This serves to update the staff's knowledge and skills and improve best practices for completing various tasks and responsibilities. An important point concerning this type of approach is that active participation is necessary for retention. In some of my experience, in-servicing, and I'm sure y'all can relate, often occurs during huddle times or through roving in-service approaches where there can be a long list of other priorities. My patient needs pain meds, I need to get my patient to the OR, my patient needs to be transferred, whatever it is. The education becomes something that needs to be checkmarked, signed, completed quickly so they can move on to other high priority items. In-servicing, especially roving, ignores the needs of the adult learner. So these are the adult learning principles. 1, the need to know. Why do I need to know this? 2, the learner's self-concept. I'm responsible for my own decisions. 3, the role of the learner's experiences. I have experiences which I value and you should respect that. 4, the readiness to learn. I need to learn because my situation is changing. 5, the orientation to learning. Learning will help me deal with the situation in which I find myself. And the last one, 6, the motivation. I learn because I want to. These 6 principles help educators and leaders improve the efficiency of learning and choose the correct modality for learning. The utilization of the learning principles is imperative and helps us transition to a need for multiple modes of education. So what we really need is multiple modes, multiple strategies to help the clinician at the bedside. Yes, we need didactic lectures. Yes, we need in-servicing, but yes, we need something tangible real-time. Real-time resources, in-the-moment support, just-in-time training, or whatever you want to call it, this achieves adult learning principles, especially learning that is self-directed and practical relevant to a learner's current needs. One main factor contributing to a greater involvement of the clinician in the education is them being able to guide their own learning, self-directed. It makes learning as needed when needed, so availability and accessibility. From an organizational perspective, like we discussed before, financial constraints and conflicts with hospital goals, staffing, acuity can conflict with the nature and goals of educational programs. With real-time training, such organizational challenges can be reduced or maybe even eliminated. If anything, COVID taught us that clinicians can pivot if they know what and where their resources are. Maintaining a steady level of comfort and competence for clinicians is a universal challenge. This is our problem here, especially when you have interventions that are not regularly performed. There's a patient safety threat related to skill decay. Skill decay or skill atrophy or skill maintenance, I've heard it called several things. It's the loss or decay of acquired skills, including knowledge, after periods of non-use. It's shown here in the first graphic. Studies suggest a marked decay or loss in technical skills starts anywhere from 2 weeks to several months after training. Research among residents demonstrates that the greatest decay is with technical skills, specifically skills that are more complex and having longer periods of not using that skill. It's similar to the Ebbinghaus forgetting curve, which outlines that learned information fades over time. There are a number of factors that affect our ability to remember, such as prior knowledge, the importance of the topic, repetition. So I'm not saying that everyone forgets the same. Learners do forget at different rates, but there tends to be a rapid loss initially. After 20 minutes, about 58% of the information is retained. After 1 hour, about 44% is retained. After 1 day, only 33% is left. And at about 6 days to a week after, only 25% remains. It reminds me, I was doing this presentation a week or so with my fiance, and he promised to remember 100%. He stayed real focused, but even with that young love, he forgot everything I said. So hope that's not the case for y'all. So what is our solution? I don't know about y'all, but I love watching real estate shows, especially this one, Selling the OC. And this one gives us our solution. So let me pull it up.
I love it. Even though Ali hasn't got her license yet, it's so important to go to as many viewings, as many showings, as many open houses as you can. You learn the job on the job. Let it up, yeah!
By the way, that Laguna Beach house was only 4 or 5 million, no big deal. So the solution we'll be discussing is just-in-time training. Because, I hope you saw the video, but like Polly explained, what better way to learn the job or retain information than on the job? Just-in-time training, or JIT, which I'll refer to it as, is a strategy that has been used in the manufacturing industry for individuals who must execute rarely performed tasks or operations in an environment that cannot tolerate error. Little history lesson. The car manufacturer Toyota created the approach after years of trial and error. After World War II, Japan faced difficult problems. They didn't have a lot of cash or hands, and resources were scarce. Sounds familiar to some of the problems we have, right? Limited resources, short staffing. So Toyota transitioned to just-in-time production. The company would only make cars once people placed an order and in the exact amount needed. The aim, what they did was they brought parts to the warehouse only when they were needed and ready for install. The approach proved efficient and eliminated unnecessary waste. When applied to clinician learning, the approach allows you to provide updated knowledge and skills immediately to learners, and as a result, they start using these new skills right away. So the main goal of the just-in-time approach in the workplace is efficiency, just like it was, for Toyota. The strategy uses a specific task-driven intervention to immediately address and identify knowledge or skill gap. Because it is extremely focused, well-designed JIT interventions are brief. They're 2 to 9 minutes, which is good because I've read the average adult attention span is about 10 minutes, meaning I've lost all of you by now, but the short time allows JIT to be used at the bedside during the care of critically ill or unstable patients. JIT can be user-driven or instructor-driven. The user-driven component allows clinicians to independently obtain the specific knowledge they need to safely perform a task. The instructor-driven component allows for real-time support and feedback exchange. By design, JIT should facilitate immediate acquisition of knowledge and clinical skills at the bedside and encourage self-directed learning with situation-appropriate content. So let's look at just-in-time training with the adult learning principles. I need to know this because I have this piece of equipment now. I'm responsible for learning this because I'm caring for this type of patient today. I have experiences with the TBI population, which are valuable, but I just need a refresher. I need to learn this now because my patient's condition is changing and they're going to have this device. Learning this now will help me care for my patient's current needs. I learn because I want to know how to best care for my patient. It looks like just-in-time training meets them all, right? I love this concept. I hope you all do too. We really have two choices when it comes to education to make it very simple. We can learn things that we think might be useful in the future and try to remember everything we've learned just in case. Or we can wait until we actually need to apply the information and learn it then, just in time. Healthcare does require some just-in-case learning since we need a broad knowledge base, right? We need this for pathologies and treatment standards and assessment techniques. However, in training orientation, we cannot and we will not cover every type of device, every product, every type of intervention you may experience. Instead, some of this could be just-in-time training where the material is supplied as you need it and applied immediately, which helps with the retention of content. Just-in-case learning should be used to grasp the larger concepts within a broad subject. Just-in-time learning is extremely beneficial in fields like ours that are constantly changing and ever evolving. I'm going to give you an example, a neuro example, because that's my background. You have to know about a traumatic brain injury patient and what you can expect for interventions. Neuro assessments, ICP monitoring, treatments for high ICP. But your patient gets an ICP monitor that you have never used before, so you're able to do just-in-time training on how to manage that specific monitor. Another example that comes to mind is the ever-dreaded annual module completion. I used to do a module every year, as I'm sure many of you have, on blood administration. But when it came to administering blood for my patient, what did I use? I didn't remember everything from the module, but I knew we kept a binder with step-by-step instructions that I would run and find. So we can't implement this with everything, but where can we use this? Where is it beneficial? First, it is beneficial with high-risk, low-volume therapies. These are interventions that are practiced infrequently and carry an increased risk to patients because of their complexity. Clinicians are required to competently manage these interventions. However, as we've reiterated, competency is a challenge. Research demonstrates that after a JIT intervention, there can be a marked reduction in adverse events in the high-risk, low-volume procedure. In addition, there can be overall improvement in competence. There have been some post-JIT questionnaires that demonstrate clinicians perceive the just-in-time training as resulting in safer working environments and improved overall patient care. Second, as technologies advance, new therapies are created, healthcare changes, the unique needs of our patients are becoming increasingly complex. Education needs to be consistent, and while clinicians need to practice skills to remain competent, they also have to know where their resources are. Third, there is often limited time to prepare for new interventions. Historically, what I've used is learners, would gain the technical skill by the see one, do one, teach one mantra. The idea of warming up or rehearsing before an event has shown promise in sports and music. There's also some research to support this warm up can improve technical performance in the healthcare setting as well. And that's what JIT is. It's a warm up. JIT can provide cost-effective, real-time learning that overcomes the challenges encountered in the clinical setting. Bedside teaching is integrated with clinical care, enabling clinicians to learn in an authentic context. The JIT approach facilitates the delivery of time-relevant education with an increased emphasis on providing on-the-job teaching as it becomes required. Now that we've talked about the benefits, let's briefly talk about several theories that support the use of just-in-time training. Learning through practice theory. This supports that workplaces are learning environments, and by optimizing the experiences that the workplace provides, it can assist in the development of skills and knowledge required for performance. What this does is it places the responsibility on the learner to engage in their learning and then transfer that knowledge to the new demands of their patient or their changing environment. Constructivism theory. Learners are viewed as active constructors of knowledge. As we think and act, we learn. Through just-in-time training, it works to engage in goal-directed activities that are sources of knowledge construction. Experiential learning theory. Kolb's theory focuses on learning through real-time experiences, so clinicians are better prepared for the next time they're faced with that same problem, that same task, that same product. Just-in-time training is experiential learning where learners apply new knowledge immediately. And the last one is the American Association of Critical Care Nurses Synergy Model for Patient Care. This model is specifically for nurses. It talks about how the patient's needs drive the nurse's competencies needed for care. So it's suggesting that optimal patient outcomes happen when nursing competencies match patient characteristics. JIT can provide the nurse with the just-in-time education to help increase their competencies required for that patient-specific care. So just-in-time training is supported, see that, but does it work? We're going to look at 4 examples. They're all pulled from the literature where just-in-time training was utilized in the healthcare setting. The first study included the Berlin Heart and CRRT, continuous renal replacement therapy. Their objective was to decrease rates of patient safety events involving these high-risk, low-volume therapies and improve bedside nurse comfort. What they did was incorporated the use of a real-time checklist available throughout the shift and a demonstration with the charge nurse where the charge nurse provided feedback. The process took less than 10 minutes. This is an example of, like we talked about, JIT having a user-driven component and an instructor-driven component. Some include one or the other, this one includes both. The results. For the Berlin Heart portion, prior to the just-in-time training, there were 9.2 documented safety events. After the JIT, this decreased 65% to a rate of 3.2 events. Results for the CRRT portion is the second circle. Prior to the JIT, safety events totaled 120.7. After the just-in-time training, this decreased 78% to a rate of only 26.2 events. In addition, over 83% agreed or strongly agreed to feeling more comfortable caring for patients receiving these therapies. And that's what we want. Okay, so the next article. This was a systematic review looking at clinical procedures. The objective was to assess the effects of JIT simulation training versus no JIT training on provider performance, and patient complications following clinical procedures. The intervention group received just-in-time training within 24 hours of the anticipated clinical procedure. The control group received no just-in-time training. They looked at multiple procedures and interventions. I remember reading they looked at things such as central line dressing change, intubation, lumbar puncture, lap choles. And they also looked at these procedures completed by a range of providers, right? Nurses, doctors, residents, APPs. The results, compared with no JIT, the use of just-in-time training was an effective means of improving measures of procedural performance across the range of surgical and non-surgical procedures. Next was an article looking at clinical deterioration. The objective was to implement and evaluate a nursing JIT program for the recognition and response to patient deterioration. JIT was implemented in a 508-bed hospital that was over a 12-month time period, and there were over 534 bedside nursing encounters, and these occurred in general med-surg units. They excluded specialty areas. A clinical deterioration educator would be alerted when patients were identified as being at risk for clinical deterioration. There were several flags of concern, but some of the ones I remember were, recent discharge from an ICU, extensive comorbidities. The educator would prompt staff at the bedside to identify the patient's risk of deterioration, talk about possible causes, and brainstorm appropriate immediate interventions. So the JIT included bedside education, debriefing, and reflection. During the study, the need for the educator to recommend that the nurses escalate care reduced in prevalence from 20% to 5.5%. Also, over 95% of the nurses felt that their learning during the just-in-time training was transferable to the care of future patients, which is a huge benefit. Okay, so we're at our last example. This is with the placement of transvenous pacemakers. Their objective was to evaluate the impact of JIT interventions on TVP placement during a simulated patient event. There were board-certified emergency med physicians from 2 different hospitals. The JIT intervention consisted of a portable bedside computer-based program. It included 2 main components. The first was a 30-second refresher video. It had audio narration of the key steps of TVP placement. And the second was a step-by-step checklist. Groups were similar at baseline across all outcomes. Providers in the JIT group demonstrated statistically significant improvement in the technical skill of TVP placement. What I think is more important is the second result. Individuals in the control group with no just-in-time training skipped significantly more critical actions that could either prevent the successful completion of TVP placement or pose a significant safety threat to the patient. The authors concluded that the JIT intervention improved procedure performance, suggesting a role for just-in-time training in rarely performed procedures. And I think this statement is applicable to all the studies and articles we looked at, right? There is a role for just-in-time training in healthcare. Medical device companies are starting to utilize just-in-time training too. Here are 3 examples we're going to look at. The use of QR codes. They take you to real-time resources of videos. You can see here a nurse is working with an EVD, has a reference tag with a QR code that she scans and can view videos demonstrating how to use the EVD, such as how to prime or how to level the drain. The Moberg multimodality monitor has embedded animations that show how to connect each device. You can see in this video the nurse is unsure how to connect the Moberg to another device, so she uses the step-by-step animations to walk through how to do it. This is at the patient's bedside while she's doing it. And most recently, the newest generation Camino has embedded training videos. There are videos that walk a neurosurgeon or resident through how to zero the ICP catheter, or this one shows the nurse how to synchronize the Camino to their bedside monitor. So again, this just-in-time training achieves our adult learning principles, and this was the example I used earlier. I need to know this because my patient is getting a bolt today. I have experiences with TBI, but I need a refresher. I want to learn about the Camino and the bolts because I want to know how to best take care of my patient today. So, since I know you're going to lose 75% of this presentation by next week, I hope you remember this slide. A JIT intervention requires support from healthcare administration, leaders, and bedside clinicians to be successfully implemented, which may be a valid alternative to more expensive educational programs. A JIT approach allows educators and managers to balance factors, education time, relevant education, by keeping clinicians in the clinical setting while providing authentic learning experiences. Although some of the studies I shared, they're small, just-in-time training has been implemented effectively as an education modality that is well received by staff and leads to an improvement in staff comfort, competence, and patient safety. I just want to stress that I'm not knocking the other modalities, right? I tend to use all approaches, multimodal, to tackle the same topic, especially when I was an educator covering the neuroscience division. I used a didactic lecture to teach NeuroCore to the new nurses, and we did hands-on simulation after NeuroCore to practice skills associated with the lecture topics. We did in-servicing on brain drains following NeuroCore, and then real-time QR codes and a brain drain board for reference. So it's really all of them, but today was meant to highlight the underutilized just-in-time approach. To summarize, as we discussed, there are a lot of challenges in healthcare, but luckily there are many different modalities of education to help us overcome these. I hope today you realize the benefits of just-in-time training to increase comfort and competence among your teams, since it provides time-relevant and situation-appropriate content. These are some of my references used today. Happy to share the total list. And thank you. Thank you all for your time today. Thank you for everything you do for educating our clinicians, and to my neuroscience nurses out there, happy Neuroscience Nurses Week.
Great presentation. So we have a question here. This is from our colleague, Ashley. I like the concept of just-in-time training, and I think it matches well with the synergy model for patient care. How can we utilize these concepts with our preceptors to ensure they can provide this model, just-in-time training with new hires? You kind of touched that towards the end about, getting the administration, other people involved, but many times it's how do you do that? To adopt this type of model.
Yeah, that's a good question. I love our preceptors. I love being a preceptor. I think the biggest thing is knowing where the resources are, right? So developing that content, making it available, making it accessible across all shifts, all times, so that those preceptors know where to lean in and what they can pull. So I remember, something as simple as a suture pad to practice suturing. We had this little sponge. It had skin-like covering. They knew where to find it to practice that skill prior to having their, orientee do it on the patient. So I think it doesn't have to be big. It can start really small, but providing and investing in those resources so that they're available to your team.
Okay, thank you. Our colleague Holly writes, thank you, Judy. Do you have tips for getting our teams to access just-in-time training 24/7 to take the initiative when leaders and educators aren't present?
That's the barrier, right? So how do you get them engaged? How do you get them interested? I think it's about creating that culture, right? I think it's manifesting that, being, initially it's going to be a learning curve and an adaptation, but I think it's really just making that a part of their everyday practice, right? So the more you do it, the more you're just used to it. So I think Ashley brought up a good point of, instilling that in the preceptors so that that's cascaded down, and just making sure that they know that is available to them.
Okay, thank you. Maybe you can just briefly tell for the audience and myself included, what is the training required from graduating nursing school? And you showed the picture of the some neuromonitoring devices, the Moberg and the Camino, and the nurses there in the patient's room working with getting some assistance with the QR codes and so forth. How do you get to that place? Yeah, in view of the younger people now, other people have left because of the epidemic. Obviously, there's a shortage, education gaps, and so forth.
You're saying, how do we get them comfortable with the devices?
Correct. How do you get there from graduating nursing school to get into that neurotrauma unit?
Yeah, so like we talked about briefly at the beginning, George asked about how much neuro is covered in nursing school, and I think we all know that's a barrier for the neuro team on, but I think nurses in nursing school are prepared for entry-level nurse competency. So to your point, George, they're not going to be covered. Camino's not going to be covered. You know, that's a specific device, and you know, ICP monitoring may not even be covered. I'm not very familiar with the curriculum as specifically, but I think it's in orientation, a lot of it, like Polly said, my girl, on the job training. So it's getting those patients in orientation. It's knowing that while you may be seeing this right now, the next time you have this resource, so you know that you'll be able to get that refresher, that warm up again. It's just getting them comfortable with the realization that it's okay to not know every device right away, right? Everything is so overwhelming, and it's just that they have resources, whether that's a person or whether that's that QR code or that video refresher, whatever it is.
Thank you. We have another one from Ashley. I think Ashley will be the one that probably retains more than 75%. She's asking excellent questions here. Do you have any books or resources you would recommend for us non-educators who can use to learn more about education styles, interventions, and tactics?
If this is Ashley Higgins or if it's another Ashley, I would be happy to share. I, of course, can be a resource, but I do have some references, and if you shoot me an email, I'll be happy to share those. A lot of it is, articles and things that I've found and webinars that I've logged into, but I'm happy to share the resources that I have, actually.
And on behalf of Natus and our Neurotraining Academy, it's been a pleasure having you join us. And again, we would like to thank our speaker for a fantastic presentation, Julie Pagel. And this will conclude our presentation. Thanks everyone for your participation. Enjoy the rest of your day or evening, and we will look forward to seeing you next time.